Hi, I'm Sarah Patterson and this is my paramedic cardioversion OSCE. So today we've been dispatched to a 55-year-old male, chief complaint being chest pain and a collapse. So today he's had an acute onset of chest pain and collapse and he's unable to stand due to his dizziness. He's got a history of hypertension, ischemic heart disease and previous myocardial infarction 5 years ago, but this current chest pain he feels different to usual. He's on sildenafil and aspirin. So we've gotten a full assessment, full set of vital signs and history from the patient's family. So the vital signs came back as a heart rate of 170 beats per minute. So he's in a wide complex tachycardia, as we can see. Blood pressure of 70 on 40, so he's hypotensive. Respiration rate of 24, so it's slightly increased. VGL of 7.6 and a temperature of 37. So going through our differential diagnoses, I can rule out a few things. So thinking about sepsis, the patient's family said he's been well recently. He hasn't had any recent cough, cold, flu or fevers. His temperature also came back as within a normal limit. So wouldn't be thinking sepsis. Thinking about electrolyte imbalance, so the patient's family said he doesn't have any renal issues and he's not on dialysis. And then also thinking about sodium channel imbalance, so this is caused by tricyclic antidepressants, and the patient's family said that he's not on any of these, so wouldn't be thinking that either. So differentiating, also with sepsis, just to keep in the back of your mind, people in sepsis with a left bundle branch block can also develop a wide complex tachycardia, so just something to think about as well. So differentiating VT from SVT. So in SVT, you are not as likely to be in as a severe compromise as you would in VT. So our patient is unable to obey commands. Can you squeeze my hands, Peter? Yeah, so severely compromised. The patient's family also said he doesn't have a history of SVT, so that's why we'd be leaning towards VT. And also looking at the monitor, in SVT you're likely to see P waves, and I don't see any P waves, so that's why I'm thinking VT. So setting up for our cardioversion, we have a towel underneath the patient's head to position the airway properly and support his airway. He is managing it on his own at the moment, but just something to keep in mind. Also, we've got an acute mask with 6 litres of oxygen attached. We've got our defib pads attached as he looks like he's at high risk of cardiac arrest. We've got our 12 lead attached, which shows VT. We got our blood pressure, we've got bilateral IV access, so one is for medications that might be given later on, and the other one could be used for fluids, which we will be thinking of after we deliver the shocks. We've also gotten our bag valve mask out and our airway equipment, just in case the patient does go into cardiac arrest. So now doing our cardioversion, what I'm going to do is I'm going to get my offsider to read out my checklist and make sure we're ready to do the cardioversion.
Place pads in either the apex, sternum or anterior-posterior position in addition to the ECG electrodes.
Yep, so we've got our apex sternum position with the pads. We've also got all our ECG leads still attached.
Ensure the defib is in manual mode.
Yep, so it's in manual mode.
Select a lead with visible R wave and ensure artifact is minimised.
Yep, so I can clearly see the R wave quite well and our patient isn't really moving, so we don't have much artifacts.
Select synchronised mode.
Yep, so it's in synchronised mode.
Confirm there is a detection symbol above every QRS complex.
So yes, I can see a detection symbol above every QRS, and I can see from this ECG that he's in VT as well.
Ensure the patient has received adequate sedation if indicated.
So for this, when paramedics cardiovert patients, it is only when the patient is in severe compromise, so sedation wouldn't be required for this. So just checking he's still in severe compromise. So Peter, can you squeeze my hands? So he's not obeying my commands, he's still hypotensive, he's got an increased respiration rate, so shortness of breath, and the patient just looks generally unwell, so he's still severely compromised.
Select the joules, charge the defib and confirm everyone is clear.
Cool. So it's on 200 joules, which is the max amount of joules. So just charging the monitor. Everyone clear? Yep, so it's fully charged.
Push and hold the shock button until the shock is delivered.
Cool, so everyone clear, shocking. Yep, so the shock's been delivered.
Determine the rhythm and the level of cardiovascular compromise.
Cool, so I'll just get another orange out. So the patient is still in VT, so that was an unsuccessful shock. Just rechecking his airway. So his airway is still patent, his breathing is still increased, still the same as before, and his circulation is still the same as well. Peter, can you squeeze my hands? Yeah, so he's not obeying my commands. He's still hypotensive, still increased respiration rate, and he still looks quite generally unwell, so severely compromised.
If administering a second cardioversion, confirm the defibrillator is still in synchronized mode.
Oh, so it's still in synchronized mode. We're going to do another cardioversion just because that one didn't work. So I'll get my offsider to read the checklist off again.
Place pads in the apex, sternum or anterior-posterior position in addition to the ECG electrodes.
Yep, so the pads are still in place and the electrodes are still attached as well.
Ensure that defib is in manual mode.
Yep, so it's still in manual mode.
Select a lead with visible R wave and ensure the artifact is minimized.
Yep, so the patient isn't moving, so we can quite clearly see that there's no artifact, and I can see the R wave pretty clearly.
Select synchronized mode.
Yep, so it's still in synchronized mode.
Confirm there is a detection symbol above every QRS complex.
Yep, so I can see a detection symbol above every QRS.
Ensure the patient has received adequate sedation if indicated.
So as I said before, sedation for this patient isn't required. Indicated, sorry.
Select the joules, charge the defib and confirm everyone is clear.
So it's still on the max joules, which is 200, so just going to charge the monitor. Everyone clear? Yep, so it's all charged.
Press and hold the shock button until shock is delivered.
Oh, everyone clear? Shocking. Oh, so that shock's been delivered.
Determine the rhythm and the level of cardiovascular compromise.
I'll just get another printout. So the patient is still in VT, so that second shock we did was still unsuccessful. So just rechecking his ABCs again, so his airway is still patent, his breathing is still increased, circulation is still the same. And Peter, can you squeeze my hands? He's not obeying my commands, so he's still hypotensive, looks generally unwell, shortness of breath, so still severely compromised. So now that we've given 2 shocks, we would be transporting to hospital. We'd call for backup, either meet them en route, and we could also call clinical and ask for outer scope. So we could ask to do a chemical cardioversion. So we could do the chemical cardioversion with amiodarone. We could also, if the patient was able to obey commands, we could, for sedation, we could use 0.5 milligrams per kg of ketamine. Other than that, we would meet back up en route. We'd keep monitoring the patient's vital signs, GCS. We would also think about giving fluids at this time, and yeah.